All right, we'll go ahead and get started. So again, this is our AO Journal Club this evening, focusing on practice influencing articles with Dr. Chip Rout as our guest. I'm Nick Romeo from Cleveland, Ohio. I'll be the moderator tonight. Our faculty presenters, Dr. John Kopp from Hattiesburg, Mississippi, Paul Purdue from VCU and Richmond, Virginia, and of course, Dr. Rout from Houston. Here are the financial disclosures for everyone participating. Just a quick comment on CME. There are 7.5 Category 1 CME credits available for this Journal Club series. You do have to participate in the entire series in order to obtain the CME. At the conclusion of the series, you'll receive an email link 24 hours afterwards, at which point you'll receive a questionnaire and be able to claim your credit. Quick statement from AO North America. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries, does not endorse nor promote the use of any product, service, or commercial entities. Equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience only. If you do have any technical questions, Chris, who is helping from AO, will be able to answer those for you. Learning objectives. Your learning objectives should be able to review the classic and current journal articles to understand why a particular study was conducted, explain how the literature advances or historically changes orthopedic practice, identify best practices based on scientific evidence, and participate in live discussion about practice defining concepts and principles. Here's our agenda for the evening. Here are the articles that we selected. These are the kind of topics we had for each article. So first is an article that significantly impacted Dr. Rout's practice. The second article is the article he's the proudest of. Third article is an article regarding a trend that did not catch on. And then we have one additional article that was a combination of impacting your practice and the proudest article. So without further ado, I'll go ahead and pass to Paul Purdue, who's going to go ahead and take it away with this article.
All right. Thanks, Dick. Again, Dr. Rout, thank you for being here. We all really appreciate it. So my article was by Burgess et al., Pelvic Ring Disruptions, the Effective Classification System and Treatment Protocols. It was published in the Journal of Trauma in 1990. It was a retrospective study of high-energy pelvic ring injuries, and the definition for them of a high-energy pelvic ring injury was a fracture that had interruption of the posterior as well as anterior pelvic ring due to a high-energy mechanism. They excluded all low energy, such as a fall from standing height. And their specific treatment modalities were based on the Young classification, fracture pattern, time from injury, associated injuries, and the hemodynamic status. Over about a 3.5 year period, they had 162 complete records spanning essentially the entire Young system other than APC 1s. They also did include isolated iliac wing fractures because of the involvement of the chest and thorax. Their overall mortality rate was 8.6%, highest being in the APC group of 20%. And they did note that they had a 0% mortality rate in their vertical shear. And this was in comparison to prior rates of being anywhere from 10 to 20% historically for mortality. And their overall average blood replacement was just under 6 units, with the highest being in the APC group. And then non-survivors in the lateral compression group, the primary cause of death was closed head injury. The APC group had the highest blood replacement in the non-survivors, and that primary cause of death was visceral and pelvic injuries. So Dr. Rout, to start things off, for us, this is a classic article that we read as med students, we read as residents, as fellows, as attendings. And even 35 years later, why was it impactful for you early on in your career and early on in your practice, and why should it and is it still impactful today for us?
Well, first of all, thank y'all for having me, and thank you for doing all of this work. Regarding the article, I work with Dr. Burgess every day, and so it's impactful and it's important because I can't say anything different because he hit me in the face. And so he wrote this article or published this article with his colleagues, and this really, I think, was the taproot of pelvic ring trauma articles, and still remains so, because they did something that no one else had really done before, especially with this number of patients. And so we were all pretty riveted by this paper and some of the other papers that Dr. Burgess had written. But we were struggling, trying to find a way to organize ourselves and organize these injuries. And this article sort of gave us that in its earliest form. And it really launched the whole, I would say, the whole subspecialty of pelvic work, at least from the North American standpoint. Back in these days, of course, you have to realize there wasn't internet. There wasn't just immediate sharing of ideas. And so we pretty much went from phone calls, mailing x-rays back and forth to people, and then going to meetings. The OTA was just getting started. The academy meetings were important. And of course, the AO meetings were really crucial for us to get together and to share ideas and to just discuss things. So I would just say that the times that we have today are really different as far as idea sharing, but this sort of launched it for a lot of us to get into the field and to work to try to figure out ways to make things better for this group of patients. Because up until this point, it was still pretty rough if you were a patient with a pelvic ring disruption and you survived.
I think something for me that I think I've sort of recognized more so as I've become more involved as an attending in the ACS and the development of treatment protocols and protocols for, the open book pelvis or pelvic hemorrhage, that when you really look back at this paper, it really is that early protocol for it. When you look at the initial assessment of the patients in the trauma bay, identification of the injury or searching for the injury, identification of the injury, and then the initial management of it or treatment of it to really, save these patients and stabilize them. Can you give us a little bit more? You alluded to, it was, tough treating these patients initially early on. Can you allude a little bit to that early on in your career? If a patient came in with this unstable pelvic ring injury, what happened to them initially before you really had these protocols and ways to guide your treatment?
It was pretty much whoever was on call was running the show, and there, emergency room medicine really wasn't a subspecialty back in those days. And so when I was a resident, it was the general surgeon on call, and that you were vulnerable to whatever experience that individual had. Fortunately, I was at Vanderbilt, and we had some really high quality, especially chief residents. In those days, the chief residents were around there for sometimes 7, 8, 9 years. And so some of those residents had incredible experience, but it was run by the person that was on call that night, and it was completely based on their clinical experience, not much on the literature. The classification of shock was evolving, what that was. And when I moved to Seattle, things were a little bit different there. There was a neurologist who ran the emergency room there for about 40 years named Mike Kopus. And Dr. Kopus was pretty much in the emergency room 24/7, 365. Hard to believe, but it's just he was a very, very devoted clinician. And this was one of his passions. In those days, there was this pneumatic anti-shock garment. You may have heard of this PASG, or MAST, military anti-shock trousers, that were basically air bladders that would surround the patient from their waist down, and they would be selectively inflated to try to, help people with resuscitation. But we really couldn't get to the patients if they were in a MAST device, because it would shroud the extremities. So things had to change. We knew things weren't perfect, but there were some, at least when I first started in Seattle, there were some pretty crucial individuals there that were leading that charge and setting a standard. Ted Hansen, Mark Swinkowski, and Dr. Kopus, I would say, were the foundational people that, at least for our group, pushed things ahead.
You mentioned the MAST trousers. Is there anything else in your career that has been a fad that fell by the wayside or something that you think has significantly added to the survival rates or the successful treatment of these patients, resuscitation screws or REBOA or anything else that's been added to these protocols when these patients come in?
Well, I would just start it at so the mast was tough because it obstructed the patient's access, and then along came the C clamp or the anti-shock clamp or the Bernese C clamp that Reinhold Gantz introduced, and then Bruce Browner had a North American equivalent to it, and we learned pretty quickly that that was a tough device for most surgeons to get on accurately without fluoroscopy. And in those days, rapid access to fluoroscopy wasn't so available. So I would say that the first thing that comes to mind is the C clamp. We were very hopeful about it, but it didn't really catch on too much. And then I'm biased because, you know, Dr. Kopis was using vacuum bean bags like you put your patients on when you do a hemi. He was wrapping vacuum bean bags around patients to stabilize their pelvis, aspirating them. And it was sort of his equivalent of a mast or a pneumatic anti-shock garment. It was a way for him to stabilize the pelvis. And then when David Teague was our fellow, he and Winston Warm one night did a circumferential sheet on a patient that had a really terrible C-type injury. And just by pulling on the limb and putting the circumferential sheet on, they made essentially a perfect reduction of what was a fairly terrible looking ring. And that's when we knew we were kind of onto something. It was simple, available, and made complete sense to us. So I would say that the C clamp offered us some hope, but was kind of harsh on the patients. And then even just cumbersome to put on, but the sheet really changed. And if you want a positive change, the vacuum bean bag easing into the circumferential sheet really changed everything, especially for a volume expanding pelvic ring injury.
Or they talk specifically in this paper about acute external fixation. And then obviously, you know, we're all taught on your anti-shock sheeting technique. Are there any instances where you will defer the sheet to an external fixator, or has your practice evolved where you're comfortable with traction, the sheet, and then going from there with these patients?
Yeah, I was pretty addicted to sheet and traction right away with that very first patient that David and Winston did. And once you see a result like that, you know, you don't have to be a genius to figure out that that's pretty impressive work. This was a really significantly displaced, you know, hemipelvis that they just sort of pulled back down and wrapped up, and it was not perfect, but it was pretty close. And so then we just pretty much used circumferential wrapping. Dr. Kopis liked it a lot, and he was always the first person there in the emergency room. And then he was also in charge of our paramedic education. So all the paramedics in the Pacific Northwest pretty much ran through us. And so that just became a standard of education for them, is learning how about every 3 months I would go over to the paramedic education building and give them a talk on orthopedic emergencies. And that would include how to apply a circumferential sheet. And we started that probably in 1993 or 94. It was really early, you know.
The concept of pelvic ring stability, I think it's interesting because one of the references in this article is a Dr. Tile paper from 1980. And they talk about around 500 cases and a very small amount needed external fixation, and an even small amount of about 24 needed internal fixation. And, you know, they talk about the really posterior fixation should only be reserved for vertically unstable pelvic ring injuries. Although they talk about in the paper anterior and posterior fixation from a biomechanical standpoint, increasing the strength of the construct and whatnot. Can you tell us a bit about, I guess, the transition or the sense of stability of the pelvic ring in your career? How, you know, initially just the posterior pelvic ring being unstable or the vertical instability, and then recognizing more the rotational instability. And then, you know, now we talk about, you know, every meeting, you know, how to identify the lateral compression type 1 injuries that are unstable versus stable. Can you talk a bit about just that the sense of stability of the pelvic ring, how that has developed in your career.
Well, Dr. Tile's article could also be included in this series. That was a real landmark article for me. I think it was, and I don't remember which year it was, but you have to realize that people were publishing just like we all do. We're a product of what we know, and intraoperative fluoroscopy really wasn't available. And when I first started, the implant for the symphysis pubis was a 2-hole 4-5 narrow DC plate with 2 6-5 cancella screws. That was the standard of care. There was no such thing as a pelvic reconstruction plate available, and there was no such thing as a cannulated screw, and the 6-5 screws only went to about 130 millimeters long, and there was no radiograph guidelines. No, you couldn't even ask. If you ask people like, what is an inlet view, they would say, oh, 45 degrees this way. And you say, well, what's an outlet view? Oh, 45 degrees this way. Well, what are you looking for? Oh, where it's injured. There was no details of like where are the tunnels, what's the anterior cortical limit of the ala, what's the slope of the ala, all of these doing, what is a dysmorph? All of these things were just like black holes. And so you have to take this literature when they say that maybe the posterior ring or that you don't really need to operate on many pelvic fractures, you have to realize it was they were just sort of reflecting the time of what was available. So when they were operating on people, it was probably pretty significant things because they didn't have all of the things that we have available to us. And then they were also aware that Dr. Kellum published a paper when he was in Toronto that's pretty famous about a 30 to 40% wound problem rate or a wound complication rate with posterior pelvic ORIF. And so that was a pretty significant article as well, because most clinicians, myself included, I really didn't want to jump into something where I was going to have 40% of my patients with wound complications. That's not a good operation. So something, when you put it all together, if you swirl all that into a smoothie, something had to change. it didn't taste good. It wasn't good. It wasn't good for you. And we just needed to get better. And so I was raised on a farm, and I had to open gates all the time for my father since I was a little kid. Whenever we go check cows, I had to open. I was gate guy, and if you learn how gates work, you can learn sometimes if you just push on the hinge, you can manipulate the gate as long as it's a fairly rigid gate, but it's always best to work on the strike side. So I understood the literature that Dr. Tile was publishing of working on the strike side, working on the symphysis pubis, and then letting the hinge sort of take care of itself. But if you're raised on a farm, that can't go very far, because you'd always, if you're trying to stabilize a gate, you'd always like to hit the strike side and hit the hinge side with somebody to help stabilize, especially if cows are pushing on or whatever. So to me, y'all have all heard of the gate theory of pain from Melzik and Walls, from when you were in medical school. This is a completely different gate theory for me, was how the ring would swing. And so once you look at enough x-rays, and when I was a resident and when I was an early attending, you could just see that typically the posterior pelvis was essentially often the hinge. And in my world on a farm, that hinge needs to be fixed as well, especially when you only have a 2-hole implant or a 4-hole or a 5-hole or 6-hole implant on very frail bone of the symphysis. It's not always going to hold. And so it was just hard for me to just buy into just always fixing the strike side and always ignoring the hinge side. That didn't make sense to me as a country hit.
How sort of to go off of that with the concept of stability, a little into the away from the acute management, but for the low energy geriatric pelvic ring injury, the common lateral compression type 1 classification type. How did that development of really sort of recognizing and not just ignoring them and saying, hey, get them up and get them walking, but really identifying, hey, some of these are going to be stable, but some of these are going to be unstable. How did that sort of develop in your practice, and how was that, I guess, response from other places when we started getting more aggressive with treating those surgically?
Well, I don't think you should pay much attention to what other people are doing, but I think you should pay all of your attention to your patients. And so if you make rounds it's pretty easy to know who's unstable and who's not. If you're just looking at x-rays all the time, you're going to have a tough time because a lot of those x-rays look normal. But then when you go to the bedside and the ladies or the man says, I can't move, I can't breathe, please don't touch my bed, I can't go to the bathroom, nothing, please don't move me, something is terribly wrong, you get an idea that just because it's non-displaced doesn't mean it's stable. And that was a very simple concept for me to understand. And that we started in, I'd say 91 or so, fixing unstable injuries in grannies. It met a lot of pushback, but we were developing these percutaneous techniques. And so the surgical load on them was pretty low. And we were doing a lot of biomechanical evaluations. We had a great biomechanical lab, and then we had a young resident named Peter Simonian, and Peter was one of the most productive people you could imagine. He just loved doing biomechanical studies, and then we would do a biomechanical study and put it together with a clinical series, and it was you didn't have to, I didn't have to listen to any of so-called expert telling me that I didn't need to be doing this. I had to listen to the patients. And then if you don't operate on a couple of them and you follow them in clinic and they come back, completely deformed, you realize very quickly that non-displaced fractures don't mean they're stable. And the patients will almost always tell you when they're unstable. So I didn't have much of a trouble. I had a lot of people barking at me and saying I was committing malpractice and all. I mean, some pretty harsh things that people would say. And I'm not saying it didn't hurt. I mean, none of that stuff doesn't feel good, but I don't really care. I had to listen to the patients and not my colleagues at some other institution that didn't even know maybe what I was doing. I think a lot of people had fear of these techniques. These techniques are dangerous. I think y'all all know that. Once you learn them, you realize there's a lot of danger in these techniques. And you could imagine how dangerous they were trying to figure them out in the lab first and then taking them to the clinic. But once you figure out how to do it, you realize the benefit of doing it. And it's just a no-brainer. So I would, I think the thing that saved me was just making rounds, listening and talking to patients, and then listening to them after surgery. They'll tell you, their pain goes from a 9 out of 10 to a 2. That's pretty dramatic. It's like nailing a femur. Same thing when you nail a femur. It's the same thing.
I think just one of my last questions is a little bit again back to these protocols, and different centers differ in their protocols in certain areas. And I think one area is the importance of someone being put in a sheet or being put in a binder and then going to angio for possible embolization, versus other centers are pretty aggressive with being put in a binder, then maybe an external fixator and pelvic packing. And I know in my center, they like to do a lot of pelvic packing, and we try to discuss with them. We try to relate to them and try to let them know where we're coming from when we eventually want to fix these injuries. What are your any recommendations for us in how to, again, after years of experience with working with trauma attendings and trying to impart your opinions and knowledge and how you're going to treat these patients and how you sort of get your point across and how you try to convince them that, hey, let's do it this way. Let's use the sheet, and you can cut holes in the sheet. IR can cut holes in the sheet. Any thoughts on that or recommendations for us younger attendings?
I think some places don't necessarily have IR expertise. And so maybe those are the centers that have gone to doing other things. I just know that when you introduce something new to me that I've never done for 20 or 25 years, and then you show me that your results really aren't any better than the results that I have, and it's a procedure that in a golden rule way, I really wouldn't want someone to do unto me as I would do unto others. I wouldn't want to be pelvic packed if I really didn't have to be. And so if you have a lot of experience doing something some way and your survivability rates are one thing, and then someone introduces something to you and says, here's a new way, it's more invasive, we're going to have to put a bunch of packs in and all that implies, but the survivability rates are, well, they're pretty much the same and maybe even a little worse. I don't need that. This is just like this is like any other tool that I don't need. It's a tool, I just don't need it. Every once in a while, maybe a patient needs it and there's some reason for it. But again, Dr. Burgess always talks about going to the strength of your institution. And I would say that there's some truth to that. But my point would be that the results of doing a reduction of volume, expanding pelvic ring injuries, and providing extrinsic support, whether it's a binder or circumferential sheet, and that if the patient's injury pattern is good for an external fixture, I don't mind if you convert over to an external fixture at all. I wouldn't take the sheet off. I think that's a good thing to use to maintain, especially if you've got a great reduction. Why would you take it off? And then put the frame on and then take the sheet off and then decide what else needs to be done. But again, we're talking about a huge spectrum of injuries with a lot of different centers. And you've also got to throw in, sometimes people just want to do something different in order to say, hear me and listen to me and see me. And I don't need that. But I understand. I like the golden rule, and I like doing unto others as I would do unto myself. And most of us would like to not have a surgery if we don't want to. And if we have to, have a simple surgery. And then one of the things my patients have taught me is nobody likes an external fixture on their pelvis. So I am a fan of internal fixation. I'm not a fan of external fixation, but I still use them. I've got a couple of patients in frames right now, but they're just in they're unusual. They're not common. They're uncommon. But if you need to use pelvic packing and it works for you and it doesn't hurt your patients, I would say have at it if that's the strength of your institution. Or hire an angiographer that doesn't mind working at night.
Nick or John, you have any questions?
I just had a quick one. There's nothing in the QA right now that I see. I just had a quick one about the pelvic sheeting that you mentioned. You said that was like around 93, correct, Dr. Rout, or sometime around then, early 90s for the sheeting that you guys.
I think Dr. Teague was a fellow in 92. So it would have been 90 spring of 92, I think.
And then you said at that time, information sharing was a bit challenging. It is such an easy technique and obviously so impactful. Was it hard or how long did it take for that technique to spill over from the Pacific Northwest to the rest of North America and to the world, just using a pelvic sheet? How long did it take for people to catch on to doing that?
It depends on if you can believe what you see with your eyes. And so we would have visiting surgeons from Switzerland, or we would have visiting surgeons from Holland come and spend time with us. And those people were hooked because they had seen several patients during their visit. They would see it used. And so those were easy. The people that were hard were just people that couldn't believe it. But you could show them x-rays, and most people are visual learners. And when you show them a widely displaced pelvic ring injury and then a really good reduction, whether it's a sacral injury or a crescent injury or a SI joint injury or an anterior ramus or a symphysis pubis or a combination or whatever it is, when you see the results of some pretty dramatic examples, most people would believe it. They weren't that reluctant to new information. But they were suspicious. People were suspicious. And then they were immediately commercialized. We thought it was a great device because they were cheap and available, and you just needed a couple of Coker clamps or 4 Coker clamps and you were good. And then, people immediately commercialized and said, I can make some money here. And then some of those doctors were, like selling pelvic binders. So it that's when it took off. The binder salesman sort of took off with it.
Great.
But you couldn't really cut holes in the binder easily. You could, that made a whole nother set of problems because you'd have to reposition the binder and stuff like that. So we stayed with the sheets. The time I was in Seattle, we didn't even buy binders. The hospital didn't even have any, at least until 2012.
John, did you have any additional questions about this one?
Many. I was going to try to maybe sneak them into the next article.
That's fine if you want, however you want to do it.
Maybe they're going to get all 7.5 hours of their CME tonight. Should I make a cup of coffee?
I wanted to talk more about cows and gates for a second, but
well, that's pretty simple to talk about.
I had a question real quick in the QA. What is your indication for resuscitation screw on vertical unstable pelvises?
Well, we use iliosacral screws as resuscitation tools when just about everything else isn't working. And so you'll have a small population, usually even in a busy center, you'll have 2, maybe 3 patients per year with posterior ring injuries. Almost always it's a sacroiliac injury and usually bilateral, and they're just not doing well. You've wrapped them up, you filled them up, you warmed them up, you've squirted them, you've embolized them. Everything has sort of been done. Their chest is good, their belly's good, their limbs aren't broken, and it's just pelvic related ongoing bleeding. And then you cut a hole. If as long as they're lined up enough and you can sort of manipulate it to where it's mostly just a distraction problem, and you can get an iliosacral lag screw in, that can be a pretty dramatic resuscitation tool, similar to the C-clamp. Ray Wright wrote a paper one time of using the C-clamp first to kind of get it even closer and then adding the iliosacral screw. The only problem with that is a lot of us put the C-clamp right in the way of where we want to put the screw, and then it's just kind of there in the field. It's kind of cumbersome. So, but it's not very common to need a resuscitation screw, but when you need it, you know it, and when you do it and it works, it's pretty dramatic. It's a dramatic tool.
Great, thanks. All right, we'll go ahead and get moving to the next one then.
Cool. I got the second paper here. It's early results of percutaneous iliosacral screws placed with the patient in the supine position. Dr. Rout is first author back in 95. 68 patients, about half men, half women, collected respectively from 89 to 92, sort of all ages, 11 to 72. It was, my guess is all the patients they had, but the mean age was as expected, about 32, and a variety of mechanisms. Vast majority were MVCs, but others, as you can see there. At the time they were using the tile classification. And it's worth noting, if you add up all the C's, like 60-70% of the injuries had at least a unilateral complete injury, with a third having a unilateral incomplete injury with those B1s. With a variety of associated injuries, those patients were included. All the incomplete injuries were reduced closed. All of the complete posterior disruptions were treated with open reduction. And some pretty impressive results. No infections or non-unions, despite having a few bladder-related injuries. But I believe 4 bladder injuries in the cases presented. And they scrutinized their reductions, post-op CT scans. They had 7 joint malreductions, 5 fracture malreductions, several screw-related issues, predominantly in the obese patients, and then 3 complete failures. One of the patients had severe spasticity. One had single screw fixation unilaterally without anterior fixation, and they ended up with a flexion deformity. And then the third they reported was just underfixed. I thought this was a really interesting paper. I think worth noting is 1989, the year that Dr. Rout began collecting his series in the supine position, is the same year that Dr. Matta at the time was publishing and popularizing, might not be the right word, but discussing doing this in the prone position. And getting ahead of myself a little bit to the fourth paper, in the discussion they talked about posterior ring was fixed when indicated, which, reading between the lines, was very indicative of the controversies at the time, I think, of fixing the front versus fixing the back, and how the evolution of these treatments were ongoing. Paul kind of beat me to a little bit my first question, because as I read this paper and thought about the historical context in the Young Burgess classification paper, 40% of those patients were treated non-operatively, and some with just X fixes. And that is, I think, very relevant as well. This was a panacea of opportunity. And my first question for you, Dr. Rout, was going to be sort of, what was your inspiration to develop this all supine technique? And it was, whether it was the high complication rates related to prone approaches, or was it just the intuitive benefits of being able to access the front and the back in one position? And it sounds like it might have also been a little bit of just living life and common sense and understand, like the hinge gait theory, which is really interesting to hear.
Well, I think putting people prone is cumbersome, and it still is, even though I've done it my whole career. it's just cumbersome. And polytraumatized or even just regular old traumatized patients, it's hard to do. And so I would just say it just came from the fixation of the reduction and fixation of the front seemed to do indirect reductions of the back. And I had an attending that told me that doing supine iliosacral screws was impossible. And, you know, that's about the only thing you need to tell me, was that something is impossible, because I don't think that we have to just accept things like that. So I guess if I'd have been a real good student, I would have said, yes, sir, and moved on. But I just figured if we could prop the patient up a little bit and get them off the table. And I had an attending when I was a fellow, and I had a great attending when I was a resident. And they were very, very encouraging to develop this. And, you know, Mark Swinkowski was a fantastic attending to me and a good colleague of mine at Harborview, and was very, very encouraging about doing these things. And then I knew from talking to people at meetings across the country that no one really understood this technique. You guys can talk to people. It's like talking to a teenager. You can talk to someone and you say, like, do you know how to ride a motorcycle? Say, oh yeah, I ride a motorcycle real good. It's like, well, then how do you progress when you're clutching on the left? Like, if you want to carry something, what do you do? And it's like, and you realize they don't really know how to ride a motorcycle. And so I would go to meetings and ask people, like, how do you put your screws in? And it would be like, yeah, I use the inlet outlet, the AP, I put it in there, you know, and just put it in, you know, it's not that big a deal. And it's like, okay, you could just strike people off the list of people that you thought might know how to do it, probably didn't. And so, yeah, I don't know what to say, except I just had someone that told me it was impossible. And then I had a very supportive environment, and I had a whole lot of patients to take care of. And I had a really good attending when I was a fellow that sort of stimulated my interest in it. And he's a co-author on this paper, Dr. Mayo. And I don't know what else to say. I was working in an enriched environment, and I was responsible for taking care of a pretty large burden of patients. I had been a resident, and we didn't fix a lot of fractures at all. And if you have an experience of taking care of people with unstable pelvic ring injuries and not managing them with operative management, you'll realize that something has to be done. So that's where most of it came. Phil Krieger was our resident. Peter Simonian was a resident, and Dr. Mayo was my attending, and then my colleague.
Great. Within the paper, there was a really, really nice description of your sequence of reduction. So unilateral injuries, you would place a Schantz pin in the ipsilateral pillar. Contralateral, or bilateral injuries, you may add a additional Schantz pin. Now I think that's a technique that I sort of take so for granted, because that's the only way I've seen it. Was that a learning curve where you started with ball spikes or other adjunctive instruments and worked up to using the femoral distractor? What did you do to identify these like corridors? Just curious about sort of your evolution of your reduction techniques as you're developing this.
Well, I was really lucky. My wife was a radiologist at Harborview, and she was in charge of CT, ultrasound, mammo. And so I could get post-op CTs because of her. And so that was one thing. The next thing is that she helped me get some of the very best x-ray techs to come to the OR. They were pretty scared of the OR, but she convinced them that it was going to be okay. And I worked with a lady named Jane Inaba, and Miss Inaba helped me while holding models and imaging models to figure out what we were looking at when we were looking at it. So she helped me to figure out what was the inlet that was necessary for an iliosacral screw, what was the outlet. We would put screws in places they shouldn't be, and then image them to make sure that we weren't being fooled by things. That's how we learned the value of the lateral sacral imaging for the alar slope. And then from the medius pillar, I don't know if you guys have trouble, but the medius pillar is really difficult for most people to put in. And if you look at some of the papers from the 80s and the 90s with the X-fixes, the pins are, 6 inches out of the bone. There may be a centimeter in the bone and 6 inches in the medius. So we knew that something had to be changed about that. So we just had to work through all of this osteology and radiology. And fortunately, my wife was very kind to me with post-op CTs, and Miss Inaba was very, very gracious and patient working with me to figure out all the imaging. So I don't know. I can't really tell you any magic except just spending a lot of time trying to figure it out.
That's really cool. This is probably an overly specific question because maybe I'm asking for myself and my own sequencing. You specifically mentioned in the paper that obviously you would not use the femoral distractor if one of the sides was not competent, because you wouldn't get that push-pull mechanism. In patients where you were open reducing or bilateral injuries with one side complete, were you actually sequencing those to do the complete side first with an
Sure.
open reduction to create competency to then use that reduction vector of up and in for the
Yeah, I think when
incomplete
you
side?
when you say competency, you mean just stability. So we would do open reductions and screws on the side that was the complete injury. And then if we had something that could be manipulated, then we would manipulate with that. You have to realize the universal distractor at that time was brand new. It came out in around 86 or 87. And so we were just learning how to deal with it too, because it was big, it was bulky, it was heavy. And then we didn't know like vectors, like we were just learning about the supraacetabular pin that came out of Hanover in the early 90s. That was a Hanover innovation that people sort of adapted quickly. But that way we could use oblique orientations to make, correct flexion, internal rotation. We could extend, but if you're asking, did we have to establish a stable side first? The answer is yes. We also were playing the chess game with using screws on one side, but then leaving room for screws on the other side. We couldn't just squat the pathway with a screw from one side and then block what we wanted to do. And so that learning that chess game of sequencing and orientations and parking screws that would allow for stability, but also allow for the other side to be fixed was a real trick. I had a fellow named Judd Ott, and I still keep in great touch with Judd in 1991 or 1990. And this was before we had cannulated screws. And Judd had done a sports medicine fellowship with Jim Andrews the year before. So he was really good with 3 dimensions. And a lot of times we would put like 2 fully threaded screws, cancella screws from one side to stent the sacrum. And then we would use a sacroiliac lag screw from the other side, and we would get a bone-to-bone thread the thread. And so that required a lot of planning in order to do that. And we didn't have PAC-SPEC in those days. We just had sheets of CT scans. So the planning we weren't scrolling. We were just putting up sheets and looking at things. But I worked with some really talented residents and colleagues and fellows, and everybody brought their own little version of expertise. And that's why I call out Judd is, I never really thought about, putting 2 from one side and then splitting the difference and then making a metal to metal fit. And essentially we were making transsacral fixation. But back in those days, we only had screws that went to 130 millimeters. We didn't have screws past 130 millimeters till 2006. So up until 2006, if we wanted transsacral stuff, we had to link screws together. We had to take 2 130s and cross their threads, if the pathway allowed it. So there was all kind of stuff like that. Plus, I had a fellow named Sam Agnew, who's just been a great colleague my whole career. And Sam went off to Arkansas and called me and said, are you seeing these weird shaped upper sacrum? And it's like, yeah, I don't know what to do with those. And so he just flew back one weekend. We pulled 100 CTs, sat in a library on a Friday and just went through 100 CTs and just sort of said, okay, that's one and that's not. And then we went through the ones that we didn't know what it was called. We thought it was some kind of segmentation error. And then we just sort of had to come up with the term dysmorphism and then look at all the common things. But that's how this body of knowledge evolved, was just people who were really focused and interested in it, getting together and then spending the time to just sort of plow through the films or whatever it took to figure it out, whether it was an x-ray tech or my wife, the radiologist, or the guy who did a sports medicine fellowship the year before, or the guy in Arkansas going, holy cow, what is this thing? It's crooked. It's really, this is weird. I can't get the screws in. Anyway, and just that's the way it all evolved.
That's
Yeah.
really, really interesting. You sort of perfectly segued into my next question as I was gonna, because I believe you published your sacral dysmorph osteology paper like 96, like right after this. And I was going to ask, presumably it was probably inspired by you very much taking to heart the, the screw related issues where you were long anteriorly out the body or
Yeah.
in out in the sacral slope, and the L5 nerve palsy. And we don't often in orthopedic literature talk about our negative results or evolve from our negative results. And so I was going to ask how the dysmorph was inspired other than just you living the struggles of treating these first 68 patients. But I
Well,
appreciate you sharing that.
the lady that had the nerve palsy, she didn't have a dysmorphism. She just had a screw that we put in the high anterior location, and she was around patient 26, and we just hadn't put a screw there before, but she had a really unstable injury, and she woke up with this sort of clumsy foot. And then we looked at the CT scan, and then it was like, how did that happen? And then Miss Inaba and I went straight to the OR, took a drill and put a screw right on top of the ALIN, took an inlet and an outlet, and realized we don't have a square here. This is not a rectangle of bone. It's an ellipsoid or whatever shape you want to call it. It's a slope. And that's when we had to start looking for something like the iliac cortical density. There was a guy from Toronto who had published in like a little manuscript a lateral sacral image that sort of showed the slope of the ALA on a lateral X-ray. And if you looked hard enough, you could see the tunnel of S1. And he became an arthroplasty surgeon, but that's what stimulated us to start looking at the lateral views for where and what was the iliac. We didn't know what the ICD was, but what was the relationship of the ICD that we were seeing on the imaging? How did it relate to the ALA? And then how did it look on the post-op imaging as well? So that all that information sort of evolved with just clinical practice, a biomechanics lab, and a really supportive, pretty much all in team of people trying to make it better. And then once Sam and I spent that day in the library, we were pretty terrified because we had been to a bunch of meetings up at that point, and nobody was really talking about this segment, this weird segment. And you go to courses and you'd see people just shoving screws into it in a dysmorph, and you go, we felt a sense of urgency to publish that paper to help people be safer. If that, I think that makes sense to anybody. That was a paper we really felt a sense of urgency for. Interestingly, the Journal of Orthopedic Trauma edited out the 5 radiographic hallmarks for looking at it. They didn't want that included. But in the old days, they would send you the proof at the very end, and you'd have to approve it. And then when you got through approving it, you'd send it back in to the assistant, not the doctors that were reviewing. And so what we did was when they sent us the galleys, we added that paragraph of these are the radiographic hallmarks, and then sent it in and just said, Michelle, they forgot this. Somehow it got dumped. It needs to go right here. And so then they published it. But you couldn't do that anymore these days either.
That's awesome. I love that.
It was an important part of the paper because it really alerted clinicians to what they needed to look for in order to identify it, in order to not hurt patients. And we weren't real happy when the reviewers edited that out, because it was the only important part of the paper.
Totally. One of the things Dr. Eastman impressed upon me in fellowship was the importance of evaluating soft tissues on the CT scan when looking at pelvic ring injury. And you had mentioned that you've been doing that obviously your whole career, where in your occult injuries, where I'm sure you put them up on your bump as a way to be able to drop your hand, and then you notice, oh, that right side that looked perfectly reduced was not reduced, because you mentioned having several occult injuries. And I guess my question or statement was, my guesstimation is after experiencing those occult injuries, you went back to the CT scans, then noted the air as like the harbinger sign. And that's how you connected those sort of dots of.
Yeah, air densities are normal in sacroiliac joints, especially in people my age. If you just look at a thousand CT scans of the lumbar spine, you'll see a lot of people with air densities in their disc and air densities in their joints. My father-in-law was an expert in the bends, and he was convinced if you biopsied that it was just nitrogen. This is just he was a guy that was really probably the global expert on decompression sickness, and he was very interested in the air that was identified on the SI joints. But he was convinced it's just nitrogen. But in trauma in younger people, when you see it in younger people, it's not a degenerative thing. It's usually a vacuum thing, and that's sort of what nitrogen does when it's exposed to pressure changes. Anyway, rapid pressure changes. Anyway, that was a clinical clue. And then when you'd stress these patients in the operating room, you'd see that there was some correlation to that. But you have to know, I mean, air densities in SI joints are, I mean, if you did a CT of me right now, I probably have SI joint air because I'm just an old man.
Totally. And that was going to be my next question. You know, I think in a 19-year-old, we raise our suspicion. What age do you have sort of a gestalt age where after 45 you're not as worried, or 55, or you know, where do you sort of draw those lines?
No, absolutely. No, we have a philosophy that was taught to me by Neil Green, which is seek disease, always seek disease, never hope for wellness. And Dr. Green was adamant about that, and I am too. And so we don't rule anything out until we rule it out. And so you can show me an SI joint that looks stone cold normal, but if the other hemipelvis is just displaced as crazy, as soon as I reduce that displaced as crazy one, the one that looks stone cold normal may just go just like that. And if you haven't seen that, just keep working. So we don't trust anything. Doesn't mean we're going to screw intact SI joints, but we're going to pay attention and we're going to stress patients sort of before we start to make sure we're not. We have the plan that we have is the plan that we need, and we can't really confirm that until we get to the operating room and have the patient asleep.
I love it. Yeah, I bring that up because I think it's super informative for the residents and people involved in this, that, you know, being really attentive to the details on CT scan, and like you said, seek disease and don't hope for wellness. So
I would never rest on anything like that. Just make sure that what you're looking at is what's looking at you.
Absolutely. And we talked about it a bit in the last paper. I was gonna, you know, within the discussion of this paper, there seemed to be some controversy with treating, you know, LC1 style injuries. But I think we sort of touched on that in the last discussion with regards to, like you said, rounding on these patients, their pain, their discomfort, their inability to mobilize. And while it was maybe controversial within the orthopedic community from your clinical experience, that, you know, that became a mainstay of your practice as being the right thing to do for those folks that were struggling. Then otherwise, rehab protocols. So has that changed for you? At the time you were doing weight of leg, crutch weight bearing, with more screws, more fixation, transiliac, transsacral screws, more robust anterior fixation, are you more aggressive with letting these folks mobilize, or?
Well, what you have to decide which decade you're talking about. So if you're talking about the 90s, we were pretty lean with fixation because we were scared we were going to hurt someone. And so we weren't just shoving screws all over the place. And then as we started to lose on some of these, we became more surgically aggressive with fixing unstable things. And so clinical experience drove more surgical, or I would say more implant aggression. And then the mechanical studies, the biomechanical studies taught us that if you fix every point on the ring, all of those implants help each other. And then in 2006, things changed a lot because then we could do transsacral fixation at the S1 level, not just at S2. And so we used to be able to put a 130 millimeter screw across S2 when it was available, but we couldn't at S1. We were having to do all these lockup things. And so one of our residents in 2009 or 2010 looked at a series of our patients from 2005 and then a series from 2008. and they were pretty much matched of C-type injuries, and found that multiple screws at multiple levels of the posterior ring with anterior fixation was ideal for dropping your failure rate to not quite zero, but almost zero, in the sub teens, into the single digits. And so if you can have a series of C-type injuries and only have a less than 7% incidence of fixation failure, you're winning. And so that was when the game changed. That was Greg Blaisdell. He was a resident with us, and he looked at the series of patients the year before we got long screws, and then a couple of years after we got long screws, and the failure rate in the before long screws was about 23%. The failure rate in the with long screws with transsacral fixation was, I think, 7 or 8%. So that was pretty simple to go into. When I moved to Texas, the patients down here are completely not completely non-compliant, but almost essentially completely non-compliant. And they will walk whenever they feel like it. And so I would tell you that I am more of a screwaholic here for the last 12 years than I was in Seattle, because I think I had a little bit more compliant population of patients in Seattle than I did. A lot of my patients also were from Alaska, Idaho, Montana, and so they were remote, and so they were kind of skittish, I think, and more compliant, because if something went wrong, they were going to have to make kind of a journey to get back to where they were fixed. So I think the patients were a little bit more protective of the repairs in the Northwest, and that might have had something to do with it as well. But yeah, I mean, right now I don't have a lot of compliant people. You come to my clinic and see my 2-week follow-ups, and pretty much all of them are crimping on in. Where are your crutches? Oh, yeah, they're in the car.
So are you still formally, allowing them to weight bear as tolerated on the incomplete side and protected on the complete, or still protecting them and then they just do their own thing?
We like to protect our repairs. I mean, it just makes sense that if you have someone that has an injury and you want to protect it, it's just like any other injury, that it makes sense to protect it if you can. So we educate them and we ask them, and we don't beg them or give them money. We don't bribe them, but maybe that's what we should do. But all we can do is educate people, say, this is what you got, this is what you should do. Have a good day. But these are grown damn men and women down here. And so they're going to do what they want to do.
We have the same patients in Mississippi.
I'm sure you do. Anyway, supine was good. And once you put a couple in, it was pretty easy to realize that you could pretty simplistically, as long as you position the patient right, you could put screws in supine without a problem.
Nick, do you want to get on to yours, or time for one more question for this one?
We only have 15 minutes left, so we should probably
All right.
go on. I think the next one will be much faster. So the next article was a biomechanical study using cadavers. It was a study published in 1993 in the Journal of Orthopedic Trauma. And the point was to evaluate implants that do not cross sacroiliac joints compared to transiliac techniques. And really, it was looking at this new local osteosynthesis, essentially plates that did not span the SI joint. I thought it was interesting they actually loaded the cadaver in a single leg stance through a total hip arthroplasty. The fixation methods include standard Harrington sacral bars, which I'll show on the next slide for those people who are unfamiliar with that. An internal fixator, which was some screws and dense sacral bone connected by a single bar, which they noted was not intended for this technique, so they expected that it would not have great stability. And then this newer local osteosynthesis technique. The failures tended to occur in the direction of the foraminal axis, and they related the failures in relation to the body weight, and the failures were the lowest for the sacral bars. So the sacral bars required the most load for failure, whereas osteosynthesis was next, and then finally the internal fixator. Just going to show people the kind of constructs here. So really the discussion part for this article is really focusing on these local osteosynthesis plates, but just really quickly, Dr. Rout, because a lot of people may not be familiar with these sacral bars, kind of where did that come from? How often is that technique being utilized, and what were the challenges with that?
Sacral bars, I think, were advocated by Dr. Tile. And this, I think you could understand why they might have had wound complications as a result of that. This was a technique that was used during my residency and early in my first couple of years. This was sort of what people considered as a gold standard for posterior ring fixation. But you don't have to do too many of these to realize you don't want to do too many more. And if you're a patient, it doesn't take you long to figure out you wish you didn't have that. So sacral bars didn't last once iliosacral screws sort of came along. Same with local osteosynthesis. This was a Hanover thing. And again, back in those days, there wasn't a lot of communication, but there were some pretty dominant trauma epicenters, and Hanover was one of them. And Harold Cherney, who's one of the authors on this, and this is when Tim Pullman, our current AO Foundation president, was we were both young guys, and this was sort of the work that he was doing. And this was what they were advocating for sacral fracture fixation to spare the SI joint, as opposed to iliosacral screws. And again, this didn't work out from being an open technique to clinicians really having trouble, locating those screws. You can see the screw in the figure A in the middle there. If you look at the one that's just medial to the fracture, you could imagine a lot of people having trouble, getting that not in the canal, not in the tunnel, into bone, and then making that durable fixation. So you asked me to have a paper about something that didn't work out. This was, at least in my younger days, this was like my primary rival, or rivals. These were the things that people were cheerleading for when I would go to meetings and try to tell them about iliosacral screws. And unfortunately, the screws worked out and this stuff didn't. But I mean, all you have to do is just look at it and you realize it's not going to compete. This can't compete. But this took a while, for people to shake off. Yeah.
Were there any other techniques that you kind of had to fight against that people were pushing for that maybe we didn't bring up?
Non-op.
Yeah.
Non-op. Yeah. I mean, there was this whole thing that, the posterior ring didn't need to be fixed in almost everybody. That was a real important thing. And then the Letournel crew was always about, Letournel's golden rule was the posterior ring always had to be fixed first. And, at least in my experience, that just didn't play out. So anyway, not much to talk about.
Yeah. All right. I think we're just going to go ahead. Unless anyone has any additional questions regarding this one, it's pretty.
No, this burned out quick. It smoldered for a while, but it didn't take long. And then once people sort of got comfortable with screws and percutaneous, I mean, you can imagine that if you knew how to do sacral bars and take care of patients and follow them, and then have to take those bubbas out, 6 months later, the iliosacral screws are going to look pretty good to you.
Do you see any indication for putting a small plate in the back of the sacrum, whether it's for provisional stabilization or not at all?
I'll let you know when I do.
Okay.
I'll call you first.
Thanks.
I'm sure there's something somewhere, but
yeah,
at this point in my life, I'm not going to be able to pull that one out.
All right, we'll go ahead and move on to the next article.
Right. So
I like this one a lot. So this one I like a lot, but go ahead.
Yeah, this is a really nice article, team approach of internal fixation of pelvic fractures with primary repairs for associated genitourinary disruptions. Dr. Rout, pardon me, and Dr. Simonian again, and a couple of urology colleagues. Published Journal Trauma 97. This was 23 patients. They excluded anyone under 18 in this paper. All of them had unstable pelvic rings with bladder disruption and complete posterior urethral injuries. Really, really interesting paper that really eloquently both described the positioning, the setup, the fixation of the pelvis, but then also the intricacies of the urologic repair. I mean, this should be an article that I think all urologists read as well. And the idea, I guess, at the time, there were a lot of people were getting suprapubic casts and what have you, and
they still are.
Right. It's a battle. but this notion of collaborating with your colleagues to develop a technique that it's in the best interest of the patient, with the orthopedic surgeon positioning the patient to set up for fixation, doing the approach, allowing the urologist to do an indirect repair to minimize the risk of a pelvic floor dissection, minimize the risk of the iatrogenic complications that can come from that, decreasing the contamination, getting a stable ring, and sort of being done. Late complications were still several. The vast majority of complications were urologic. There was one deep infection. Early complications, there was a lumbar nerve motor palsy that they reported from being from reduction. Was really interesting, hard to tell why, but sounds like you had it clamped and unclamped and no significant change in the sacrum, but it still happened. And then 3 fixation failures, which I think paralleled some of the failures from the previous papers. There was some overlap in the series. I think the most important thing for me, and Paul discussed this a bit as well when he talked about collaborating with his general surgery colleagues, is, was it just that you happened to be surrounded by great people, or were there strategies you implemented to facilitate collaboration with your trauma colleagues to evolve treatment for the best interest of the patients, to develop these techniques versus just sort of, well, the urologist knows doing a deep dissection, so that's what he does?
We had a wise, experienced urologist, Al DeFalco, toward the end of his career, who loved to operate with us, and he loved to seal bladders, and he knew that it would be good for us, since we were plating the pubis and putting hardware in the anterior ring, if he would seal the bladder at the same time. And he liked to work with us, and so that made it very easy. Jane Miller was his resident. And then she later became an attending there. And so Dr. DeFalco made things really pleasant. It took me a while to get used to prepping and draping the scrotum and the penis and the Foley into the surgical wound. The first couple of ones, I just did one of these last week, and I still don't like operating with the penis and the Foley and the scrotum in the field, but it works just fine. The urethra, I think, was really an interesting part. This was when Dr. DeFalco had these super strong magnets. And if you would just imagine a Foley catheter with one at the tip, a really strong positive magnet, and another Foley catheter with a really strong negative magnet at the tip. And he would go into the bladder for the urethral injuries and put the one magnet down the urethra and then put the other one up the penile urethra and smash. They would clamp together, and he would bring a Foley in, a big old Foley about as big as my finger, and then allow the urethral to heal around that to try to save them a late spatulation. I don't know if you've ever seen a late urethral reconstruction, but it's just not something anybody wants to have. It goes back to that old golden rule thing we talked about earlier. So Dr. DeFalco was willing to do this. He had these magnets that worked really good for realigning the urethra. And then a lot of these symptoms that you see that are urological are due to these urological injury. The lumbar palsy was an interesting guy who had hemodynamic instability, and he actually had a spine injury, so he had spinal monitoring on at the time we were doing the surgery, and he was really bleeding a lot through his symphysis. And as soon as I'd clamp his symphysis, he had a transforaminal sacral fracture. As soon as I'd clamp his symphysis, the bleeding would stop, and then the nerve monitoring guy would say, "You just lost the nerve root." And so we'd open up the symphysis a little bit. You could see the tunnel open up a little bit, say, "Oh, the nerve root's back," and then the bleeding would start again. And so it was, we had to choose bleeding or nerve root. And so we clamped the symphysis, plated the symphysis, screwed the sacrum, but his nerve root was injured as a result of that reduction, I guess, that indirect reduction of the posterior ring by just clamping the symphysis back together. I think that would have happened whether I did an X-fix or whatever it was. I was just directly clamping the pubis, and then we would get the nerve monitoring changes. I had a patient have this about 3 years ago as well. So yeah, I mean, this was just a collaborative paper working with a real expert urologist. And whenever he was in town, things were sweet. And whenever he'd leave town, he had these competitive hunting dogs. He had these field trial dogs that he would show all over the world. He was taking these little Brittany's. He was taking them all over the world and running them in competitions. And so when he was running his dogs, we were in a little bit of trouble. luckily, we got this paper published in the Journal of Trauma. We did that with intent so that a larger urological audience would see it. And I even had to, one of his colleagues one Saturday wouldn't come in because he let me know that urologists don't fix extraperitoneal bladder disruptions. And I said, well, we do here. And he goes, well, there's no publications for that. And I said, well, here's the paper and come on in, put on your scrubs and come on in. So sometimes we have to educate our peers, and luckily I don't have to do that here, and I didn't have to do that there. So usually at large centers, the urologists are pretty much in tune with this stuff, but not back in these days. But the patients still have urological symptoms, not so much infection, but they still have, urethral transection is going to stricture almost all the time. So.
You did a really nice job, a really detailed description of your like positioning and draping and all those things. And I think that's a critical component of surgery that's often overlooked. I certainly overlooked that as an intern, junior resident, et cetera, of how important it is to set yourself up right for success. How did your positioning and draping evolve at all over time of developing this technique? Did you go straight to a 2-towel sacral bump to elevate the pelvis, with manipulation of such to adjust your inlet outlets, or is this something that has evolved for you over time?
We folded up 2 blankets on the very first one I did. It just seemed to be the simplest thing around, and maybe the way I folded them over time got a little better, but I would say nothing much has changed since 1990 as far as the bump. The bump is just 2 folded OR blankets adjusted to fit the patient and then get them up off the field. It's just it's a really simple thing. But the prepping and draping with Al, that was a little harder for me just to get used to, because I never prepped and draped a scrotum and a penis. And for females, it's even harder because I've got to get under the thigh to get to the catheter to stress their repair. So when they would repair the bladder, I'd scrub out and then get a little bit of methylene blue and some saline, and then take a clamp to pinch off the Foley, and then you couldn't put the Foley in the field in a female because just of the way the anatomy is. So it's easier for a male because everything's sort of in the field. Females, it's harder.
And we talked about this a bit before as well, where you'd mentioned in the discussion posterior ring was repaired when indicated, and I assumed that was sort of to appease editors, but it sounds like from the get-go you have felt very strongly, and rightfully so, that multiple points of fixation of multiply injured pelvis benefit from stability for functional recovery, rehab, and pain control, etc.
Yeah, this has never been a controversy for me, other than if you don't know how to do screws safely. So I would just say if you don't know how to do screws safely, then you shouldn't maybe do that. But if you know how to put them in, probably one of the first patients that taught this to me was I had a guy in maybe 94, and he had a pubis that was like this, and he had an SI joint on the CT that looked, for all intents and purposes, that it was just anterior only. It wasn't complete at all. And when I clamped his pubis, I put the fluoro on just to make sure everything closed in the back, and his SI joint was still wide open. And it sure looked like an incomplete injury, but it didn't close. And so I learned a lot from that guy to realize that a lot of the things that we think we know that we're looking at, we may not really understand. And again, we talked about this earlier, is, don't trust anything until you can trust it. The other thing is it's again, I said this before, it's really hard for me to hang a human being off a 4 or a 6 or an 8-hole 3-5 recon plate only, and then just hope that parasymphyseal bone won't yield. Because if you've done enough symphyseal work, you know that sometimes that doesn't hold. And so it's always great to have the hinge side of the gate held as well. But this has never been a controversy for me. And we sorted this out early we did a lot. Peter Simonian, when he was a junior resident, we started doing biomechanical studies together. And that was one of the first things we did, was studying, the value of a screw or two on the incomplete posterior ring. We could never really make things complete, because if you do a cadaver and you section the symphysis and then you section the SI joint, the model just falls off this platform, you know. So you can't really make both front and back injuries complete. You kind of have to leave something incomplete, or else you just got a big mess trying to put it all back together. But that was one of the first things we learned, was that incomplete injuries, when they were screwed, had a lot of mechanical value to that. So this was not a no-brainer, but pretty much a no-brainer, especially after you learn how to do screws safely.
Very good. That sort of was the high points, I think, for me on this one. I think just to have such a collaborative publication, collaborative work, development of protocols with our colleagues, in and of itself is an accomplishment. And it'd be great to say 27 years later that it's easy, but it was really nice to read this and see that it is possible and can be done.
I think it's important for us to remember that, most orthopedic surgeons don't go into trauma, and they don't really like it that much. And I would say all urologists, essentially all, 99.9% of urologists don't go into urology in order to come fix a bladder with the orthopedic surgeon. But if you can establish a relationship with the urologist, let them know how important that work is to what you're doing, show them some literature, then usually that and a bottle of wine will get you a good colleague to come help you in the operating room. Sometimes it's a case of wine or whatever it is, whatever their sin is. But that's an important thing about working with your colleagues, is find their sin and then give it to them. And then they'll come help you and say, hey, remember that time I gave you that case of wine? It's like, get your ass out of bed. Let's go. You have to do whatever it takes in order to protect your patients.
Very good. That's the pearl of the night.
One thing I wanted to bring up is there was a publication this year that Dr. Rout was as an author on, looking at still, GU injuries, looking at extraperitoneal bladder injuries. And they looked back, I think the database went back to 2016, and there was still, of 68 bladder injuries, I think 13 of them still were not repaired. And they had a 17-fold increased risk of infection. So it's still obviously very substantial, but still sometimes people aren't repairing them.
Well, it's hard. You can't make people do what they don't want to do. And it's hard to have people know what it is that they need to do when you're not in their specialty. So all you can do is do the best you can to educate them and treat them like colleagues, and hope that you can generate good relationships.
Great. I had two real quick questions just to finish things off from some attendees. Does the presence of an open pelvic ring injury change your fixation consideration or timing?
Yeah, I would say that if you can avoid surface implants, you should, if you can. If you really need a surface implant and you've got an open injury, then you have to do it, and then just irrigate and treat the wound, using open techniques. I wouldn't close the wound if you can help it. And again, this is a huge spectrum. An open injury is not an open injury. I mean, this is a huge spectrum of injuries, so I don't really know what they're talking about. But if you tell me someone split from their rectum to their umbilicus through their perineum, that's going to need some work that may be a little more extensive and a little more aggressive. But if you need to plate this pubis for whatever reason, then you have to do it. But if you can manage them in a frame, that would be a good thing too. Sometimes we'll use a frame for the open ones, and then just overload the posterior ring, knowing that the frame's going to wear out anywhere from 4 to 8 weeks. Yeah.
There was one other question that was very similar. If someone has a rectal injury and a grossly unstable pelvis, do you wait until the diverting colostomy to internally fix? Apparently at their institution, they're having some pushback from general surgery on doing the diverting colostomies.
Yeah, a lot of surgeons these days are concerned about doing diversions. I'll just tell you that I've really never seen a patient hurt by a fecal diversion, but I've seen some people really hurt by not doing fecal diversion in a timely manner. It doesn't mean it has to be done on the very first night, but that needs to proceed along. But again, I'm not going to tell the general surgeons what to do, but I'll just give you my experiences. I don't think I've ever seen anyone hurt by a fecal diversion, and I've seen some people not survive as a result of not having a fecal diversion. Those are avoidable problems, you know. You can always blame it on a whole bunch of other things, but and again, that just goes back to the collegiality and sort of knowing. The other thing is a lot of times people are rotating. Y'all's generation is a generation of rotators. Everybody's kind of rotating. Are you on today? Are you off today? That kind of stuff. I don't know where y'all work and what your environment is, but you know, mine, like when Al DeFalco and I were working, we were pretty much on. You know, you just like pretty much on. You know, my wife will tell you was pretty much on. Like if it was Monday, if the day ended in a Y, I was on. And so was Al, unless Al was running his dogs. And so same with the general surgeons. You know, the general surgeons, some places are rotating all the time, and some places they're just following the patient until that's their patient. So that can also make things a little muddly, depending on what environment you work in.
All right, great. I think that's all the time we have. So thank you everyone for joining us, and obviously Dr. Rout, John, and Paul for participating and sharing your wisdom with us.
Thanks for having me, and I appreciate y'all doing all this for AO North America, and I appreciate all the people joining in. And if there's things I can clear up, I think everybody has my email, and you can send me a note.
Great, thanks.
See you later.
Thanks, everyone.
Thank you.
Next Journal Club, December 17th, topic to be determined. There's a fellows webinar coming up November 12th. There's some other additional webinars, elbow webinar October 16th, and then a scapula and glenoid December 11th. And that'd be it. Thanks, everyone.
Thank you, guys.